We often think about strength, in physical terms, what we can see. But today we're diving into a condition where profound weakness really is the defining feature.
Mm-hmm.
Chronic fatigue syndrome, or CFS,
Uh-huh.
also known as myalgic encephalomyelitis, or ME.
That's right. It's a really complex area, isn't it? Lots of people struggle to really get their heads around it.
Absolutely. So our goal with this deep dive is to sort of unpack the essentials about CFSME, make it clear, memorable, and hopefully really useful for you listening.
Yeah, we'll be using some detailed notes to give a structured overview, and we've got some memory aids, examples,
Yeah.
things to help solidify understanding.
Great, because understanding this condition, well, it's challenging.
It really is. And that overwhelming fatigue is the central thing, kind of weaving through everything for the person affected. It's not just being tired, it's fundamental.
Okay, so let's start right there, the foundations. How do we actually define chronic fatigue syndrome and myalgic encephalomyelitis? What are the key things for diagnosis?
Well, at its core, CFSME is this complex, long-term illness. The main symptom is severe fatigue, and crucially, it doesn't get better with rest.
Not like just needing a good night's sleep then.
Exactly. This
Yeah.
is a deep, persistent fatigue. It significantly cuts down someone's ability to do their daily things, enjoy life. Clinically, for a diagnosis, this fatigue needs to be disabling.
Disabling. How long does it need to last?
It needs to have been there for at least 4 months, and it has to be affecting both their mental and physical function more than 50% of the time.
Wow, more than half the time.
Yeah, yeah. And very importantly, doctors need to have ruled out other medical conditions that could be causing similar symptoms. There's no single test, you see.
Right, right. And ME and CFS, they're essentially the same condition, just different names.
Precisely. And it's worth noting, the World Health Organization actually classifies ME as a neurological disease. Health authorities recognize it too.
Okay.
Another really key thing is how unpredictable it can be. Symptoms can fluctuate, change in type, change in intensity. That adds another layer of difficulty.
That unpredictability, I imagine that makes getting a diagnosis quite tough for people.
Oh, absolutely. Many people face really long delays, sometimes years before they get a diagnosis. And unfortunately, some might even face skepticism from healthcare providers.
That must be incredibly frustrating.
Yeah, it can be really detrimental.
So the exact cause isn't known, you said, but what do the notes suggest about the etiology, the potential factors involved?
Well, like you said, no single smoking gun. But the thinking is it's likely multifactorial, a mix of things.
Oh.
A really significant number of people, maybe 50 to 80%, say their illness kicked off suddenly after something like the flu, a viral infection.
Ah, so an infection trigger is common.
Seems to be, yeah. Beyond that, we're looking at possibilities like immune system problems, hormonal imbalances, maybe a genetic predisposition, making some folks more susceptible.
Genetics too.
Potentially.
Yeah.
And also the impact of significant psychological stress. Research is really looking into how these things might interact. Maybe an infection triggers an autoimmune response in someone genetically prone.
That link between infection and the body's response sounds really critical.
It does seem to be. The notes also mention how major life stressors can impact our neuroendocrine system. That's the network linking brain, hormones, immune system.
Right.
If that gets disrupted, it can have knock-on effects. We also see signs that the HPA axis, the hypothalamus-pituitary-adrenal axis, is less responsive.
The body's stress management system.
Yeah, exactly. In CFSME, it seems sort of underactive, and that affects how the body handles stress and illness. Plus, there are changes in the sympathetic nervous system, the fight-or-flight part,
Okay.
that seems more active, and levels of stress hormones like catecholamines are altered. So overall, it points to a complex pattern of changes in the body's systems.
That is quite a lot to juggle. Is there a simpler way to remember those potential causes?
Definitely. We can use a little memory aid. VIGHP. Yeah. Virus, immune dysfunction, hormonal imbalances, genetic predisposition, and psychosocial factors. Think of them as potential pieces of the puzzle.
VIGHP.
Got it. That's helpful. Now, thinking about who gets it, are there clear risk factors? Who's more susceptible?
Well, epidemiologically, it's definitely seen more often in women. The notes suggest about a 2-to-1 ratio, women to men.
Twice as common in women.
Having a family history of CFS or similar conditions also seems to increase the risk. That hints again at that possible genetic link.
Hmm.
Experiencing significant stress, either physical or emotional, has also been associated with it starting or getting worse.
Stress as a potential trigger or exacerbator.
Right. And finally, having other conditions already like fibromyalgia or autoimmune disorders might also mean a higher chance of developing CFSME.
So let's take an example. Say a 35-year-old woman comes in. She's had persistent fatigue for 6 months after a viral illness. What's a key demographic risk factor there?
Well, the fact that she's female would be one key demographic factor to keep in mind, alongside everything else, of course. Makes sense. Okay, let's dig a bit deeper into the pathophysiology. We touched on some bits with the causes, but how does it actually work inside the body? What's going wrong?
Yeah, this is where it gets really complex, and honestly, we're still figuring out the exact mechanisms. But the current thinking points to issues in several key biological systems.
Like what?
The notes highlight irregularities in the immune system, that disruption of the HPA axis, the stress system we mentioned, and also changes in how neurotransmitters work in the brain.
Neurotransmitters, the brain's chemical messengers.
Exactly. And there's growing evidence, too, for increased inflammation and something called oxidative stress. That's like an imbalance between damaging molecules and the body's defenses.
Inflammation and oxidative stress. Okay.
It's thought that all these things together contribute to the symptoms, especially that profound fatigue and the difficulty recovering after exertion, that post-exertional malaise.
Right, the PEM. So another memory aid, perhaps, for these core areas of dysfunction.
We could use IHAN, immune system dysregulation, HPA axis abnormalities, and altered neurotransmitter function. Those seem to be the main systems affected.
IHAM. Immune, HPA, neurotransmitters.
Okay. Now, with such varied symptoms, diagnosis sounds like it heavily relies on excluding other possibilities first. What's involved in the differential diagnosis?
Oh, absolutely critical. Since there's no specific test for CFSME, you have to rule out other things that cause similar symptoms.
Like what sort of conditions?
Things like fibromyalgia, multiple sclerosis, hypothyroidism, and underactive thyroid, depression, various other chronic illnesses, too.
So it's a process of elimination.
Very much so. It relies on a really detailed history, a thorough physical exam, and specific tests to exclude those alternatives. And because of this, yeah, diagnosis can take a long time.
Right.
And sometimes someone initially thought to have ME might, down the line, turn out to have something else as more information comes to light. The differentials can also vary depending on the initial presentation.
Well, if someone's main issue is dizziness when standing, you might investigate POTS, postural orthostatic tachycardia syndrome first, before jumping to ME/CFS. Or persistent fatigue might trigger tests for thyroid issues or diabetes initially.
Okay, so let's say a patient has chronic fatigue, muscle pain, and cognitive issues, that brain fog. What are some key differentials to consider before landing on CFSME?
Right, exactly. You'd definitely be thinking about fibromyalgia, hypothyroidism, depression. Those would be high on the list to evaluate and rule out first.
Makes sense. Okay, let's shift focus slightly to who gets this. What does the epidemiology tell us, especially here in the UK?
Estimates in the UK suggest it affects somewhere between 0.2 and 0.4% of the population. It's quite a lot of people, across all age groups.
And the gender split.
As we said, more common in females, roughly 2 to 1. Onset is typically in early adulthood, but really it can start at any age.
What about psychiatric history? Is that a risk factor?
Interestingly, no. Our notes clarify that having a pre-existing psychiatric condition is not a confirmed risk factor for developing CFSME itself, though living with the illness can certainly impact mental health.
That's an important distinction.
It is. And it also affects children. Up to 2% might be affected, which can lead to long periods off school, major disruption.
That's significant for kids.
Yeah. And some data also points towards a higher incidence in socially deprived families, though the reasons for that are complex.
Okay, so what are the actual symptoms someone with CFSME experiences? What's the typical clinical picture?
The absolute defining symptom is that persistent, overwhelming fatigue lasting at least 6 months, but it rarely comes alone.
Right, you mentioned other things.
Yeah, a key hallmark is post-exertional malaise, PEM. That's where even minor physical or mental effort causes a significant worsening of symptoms later on. Fatigue, pain, cognitive fog, everything.
That sounds debilitating.
It is. Sleep problems are also really common. People often wake up feeling unrefreshed no matter how long they slept.
Unrefreshing sleep.
Okay. Cognitive difficulties. That brain fog is another big one. Affects memory, concentration, processing information. And then there's often widespread muscle and joint pain, headaches, sometimes flu-like symptoms that linger.
Are there specific criteria based on these?
Yes, there are internationally recognized diagnostic criteria.
Yeah.
Generally, besides the fatigue, they require PM, unrefreshing sleep, cognitive impairment, and a significant reduction in activity levels.
For how long?
Usually, symptoms need to be present for at least 6 months in adults, sometimes a bit shorter for children, depending on the criteria used. For me specifically, you might also see things like orthostatic intolerance, trouble standing up, temperature sensitivity, sensitivity to light or sound, and often more severe pain.
And it varies in severity.
Hugely.
Yeah.
It's a spectrum. Mild cases might mean someone can still work part-time but has to cut back socially. Very severe cases. People could be bedridden, need constant care, extremely sensitive to any stimulus.
Wow. And for kids and teens?
Similar picture. Overwhelming fatigue, worsened by minimal effort, cognitive issues, sleep problems, pain. Sadly, yeah, many can end up needing wheelchairs or being confined to bed.
That paints a really stark picture. Is there another mnemonic to help remember these core symptoms?
Yes, we can use fatigue itself.
Fatigue. Okay.
Fatigue, severe, persistent, activity intolerance due to PEM, thinking memory issues, insomnia, sleep problems, unrefreshing, generalized pain, unrefreshing sleep again, it's key, and exhaustion, profound.
Fatigue. That covers a lot of the key features. Okay. So if there's no single test, what investigations do doctors usually do if they suspect CFSME?
Right. The diagnosis is primarily clinical, based on that history and examination. But to rule out those other conditions, the differential diagnoses, doctors will order screening blood tests.
Standard stuff.
Pretty standard, yeah. Things like a full blood count, FBC, urea and electrolytes, UNE for kidney function, liver function tests, LFTs, glucose for diabetes, thyroid function test. Other tests might be done depending on the specific picture. In the UK, the referral pathway usually involves sending adults to specialist ME/CFS teams.
And children.
They typically go to a pediatrician. And if managing activity is a major issue, referral to specialist physios or occupational therapists with ME/CFS experience might be helpful.
Okay, we've covered the what, why, who, and the symptoms. Right. Let's talk management. How is CFSME usually managed, particularly in the UK system?
Well, since there's no cure currently, the focus is really on managing symptoms and trying to improve quality of life.
So what does that involve?
General strategies often include things like cognitive behavioral therapy, CBT, and learning activity management techniques, often called pacing.
Okay, CBT and pacing.
Yeah, but it's really important to be clear about CBT here. The aim isn't to suggest it's psychological. It's about developing coping strategies for the symptoms, managing within limits, improving function where possible.
Right, it's a coping tool.
Exactly. And pacing is all about finding that balance between activity and rest to avoid triggering PM. It's not about constantly pushing limits.
And what about graded exercise therapy? GT, I've heard about that.
Ah, yes. Crucially, GET is traditionally defined where you steadily increase activity regardless of symptoms, is no longer recommended by NICE guidelines in the UK for ME/CFS. Evidence suggests it can actually be harmful for some people.
Okay, that's a really important point. No GT. What else is used?
Sometimes low-dose amitriptyline might be tried for sleep problems. If pain is a major issue, referral to a pain management clinic could be useful. Individual dietary advice and making sure fluid intake is good can also help some people.
How do people manage the ups and downs, the flare-ups?
Managing flare-ups is key. It involves learning to spot early warning signs, identifying triggers like overdoing it, stress, or infection. When a flare happens, the advice is to cut back activity, prioritize rest, use self-care strategies.
And seek help if needed.
Absolutely. If things get worse or don't improve, talking to the GP or specialist team is important.
Yeah.
Regular reviews are essential anyway to monitor things and adjust the plan.
What about the really severe cases, people who are bedridden?
They need much more specialized support. Referrals to experts in severe ME are often needed. CBT and pacing still have a role, but they have to be very carefully adapted to extremely limited capacity.
Right.
Often, managing the environment is key, reducing light, sound, sensory input. And practical support is vital help with personal care, mobility aids, home adaptations. The focus remains on quality of life within severe limitations, always avoiding pushing into PM.
So, looking ahead, What's the typical outlook? What's the prognosis for someone with CFSME?
It's really variable, honestly. That's one of the challenging things. Some people do gradually improve over time. Some might even feel they recover fully.
That's hopeful.
It is. But for many others, it's a persistent long-term condition. The course often fluctuates, with good periods and bad periods, quite unpredictably.
Are there factors that influence the outcome?
Early diagnosis, getting the right management and support those seem important. But right now, we can't really predict accurately how any one person will progress. Factors sometimes linked to a tougher course include having very severe symptoms right at the start, delays in getting care, maybe a family history of severe ME, or having other health conditions alongside it.
Is it life-threatening?
Direct death from CFSME itself is rare. When deaths occur, it's usually due to complications from other coexisting illnesses. On a slightly more positive note, children and younger people generally seem to have a better prognosis overall compared to adults.
Okay. And finally, what about complications? What else can arise from living with CFSME?
Well, the biggest complication is just the huge impact on daily life and quality of life. That itself is massive. And flowing from that, you often see mental health challenges. Social isolation is common because people just can't participate like they used to. Depression and anxiety rates are higher. Productivity at work or school obviously suffers.
So psychological support is important too.
Absolutely essential. Management needs to be holistic, addressing physical symptoms and mental well-being, because outcomes vary so much that comprehensive ongoing care is just vital to manage these potential complications and help people live the best life they can within the constraints of the illness.
Wow, okay. This has been an incredibly thorough deep dive. Just to quickly recap for everyone listening, we've really unpacked the definition, the diagnostic hurdles, the potential triggers like viruses and immune issues, the risk factors like being female, the complex biology involving the immune system and HPA axis.
The importance of ruling out other conditions like thyroid problems or fibromyalgia.
Exactly. We looked at who gets it, the wide range of symptoms headlined by fatigue and PEM, but including pain and brain fog, the clinical diagnosis process, and the management strategies like pacing and symptom control. Remembering GET is not recommended.
Right. And then the variable prognosis and the significant impact on quality of life and potential mental health complications.
It's clearly a multifaceted and challenging condition.
Yeah.
But having that solid grasp of the key features, the potential causes, the management approach, that's crucial.
Definitely.
And for those of you using this for MSRA revision, remember passthemsra.com and freemsra.com have more resources. Understanding complex conditions like CFSME is definitely a journey. We hope this discussion has given you a clearer, more memorable framework